You pour out your darkest thoughts. You feel heard, understood, even comforted. And then you find out that was not a psychiatrist. That was an algorithm. Psychiatry sits at the intersection of medicine, neuroscience, and the profoundly human art of understanding another person's mind. For over a century, it has been considered perhaps the most irreplaceable of all medical specialties because it deals not with bones or tissue, but with consciousness itself. But AI is now encroaching on this sacred ground with remarkable speed. Large language models trained on millions of therapy transcripts, clinical notes, and psychiatric literature can now conduct cognitively structured conversations that patients rate as helpful, empathetic, and in some trials, clinically comparable to early-stage human-led sessions. AI diagnostic tools can analyze speech patterns, facial microexpressions, and language semantics to flag depression, anxiety, PTSD, and early-stage psychosis with accuracy that rivals junior clinicians. Mental health apps powered by AI are already the first point of contact for hundreds of millions of people worldwide, particularly in regions where psychiatrists are scarce or unaffordable. So the question psychiatrists must now face honestly is this: if a machine can listen, assess, and guide, what is it that only a human psychiatrist can truly do? Let us be precise about what psychiatric work AI can already replace or will replace very soon. Initial mental health screening and triage AI tools can assess risk level, identify presenting symptoms, and recommend care pathways with high reliability. This is already happening at scale in corporate wellness programs and national health services. Structured psychotherapy delivery, cognitive behavioral therapy, dialectical behavior therapy techniques, and guided mindfulness protocols are being delivered entirely by AI applications to millions of patients with documented improvements in outcomes. Medication monitoring and adherence tracking AI systems can track side effects, flag dangerous drug interactions, and alert clinicians when a patient's condition is deteriorating, replacing much of the routine follow-up work that consumes a psychiatrist's clinic time. Clinical documentation, the hours spent writing notes, discharge summaries, referral letters, and insurance reports are being automated by AI scribes in real time during consultations. Risk assessment for self-harm and crisis intervention AI models analyzing social media activity, wearable data, and communication patterns can predict crisis events before the patient even presents, triggering outreach without any clinician involvement. And psychoeducation, explaining diagnoses, conditions, and treatment options to patients and families is now done better by AI than by many time-pressured clinicians. So how do psychiatrists stay ahead of AI, and what must some accept about their fate? Strategy 1: Own the complexity that AI cannot navigate. The most severe, multimorbid, treatment-resistant cases, patients with complex trauma, forensic histories, or conditions that do not respond to protocol-based intervention require a depth of clinical intuition, contextual reasoning, and therapeutic relationship that AI cannot replicate. Psychiatrists who specialize in complexity will be needed more, not less. Strategy 2: Become the human supervisor of AI systems. Every AI psychiatric tool deployed in a healthcare setting needs a responsible clinician to review its outputs, validate its assessments, and manage liability. The psychiatrist of 2030 will supervise dozens of AI-assisted patient pathways simultaneously, a fundamentally different but highly valuable clinical role. Strategy 3: Develop expertise at the intersection of psychiatry and technology. Psychiatrists who understand how AI mental health tools work, their failure modes, their biases, and their ethical limitations are irreplaceable as clinical advisors, regulators, and developers. Strategy 4: Double down on the therapeutic relationship itself. The one thing no study has shown AI can replicate is the experience of being truly witnessed by another human being who has also suffered, struggled, and persisted. In long-term psychotherapy, in crisis intervention, and in the treatment of severe mental illness, that human presence remains clinically essential. And Strategy 5: Lead on ethics, advocacy, and policy. As AI reshapes mental health care globally, psychiatrists who shape regulation, protect patient rights, and ensure equitable access to care will have roles of profound societal importance that no algorithm can fill. And finally, will psychiatry be obsolete by 2030? Here is the honest and perhaps surprising verdict. Routine outpatient psychiatry, particularly medication management appointments that last 10 minutes and consist largely of asking whether side effects have changed, this is genuinely at risk of being replaced by AI-assisted systems within 5 years. Entry-level counseling and psychoeducation roles already being displaced rapidly by AI applications that are available 24 hours a day and cost a fraction of a session fee. Community mental health monitoring and follow-up AI will handle this at scale, freeing human clinicians from what is currently enormously time-consuming administrative care. But consultant-level psychiatry, working with the most complex, vulnerable, and treatment-resistant patients in the world, these clinicians become more valuable as the AI handles everything beneath them. Forensic psychiatry, psychotherapy training and supervision, psychiatric leadership, academic research, and policy roles, none of these are under serious threat. Psychiatry will not be obsolete by 2030. But it will be radically transformed. The psychiatrist who refuses to engage with AI will find their caseload narrowed and their role questioned. The psychiatrist who embraces it will have more impact, reach more patients, and practice at a level of clinical depth that no algorithm will match for decades to come. The mind is still the last frontier. Make sure you are the one mapping it.